respond very well to low-dose phenobarbital. Feature I show you, so EEG abnormalities are accentuated by sleep, as happens with Rolandic epilepsy, and with time abnormalities become less florid and eventually disappear. This is an age-related epilepsy syndrome, benign epilepsy syndrome. And this is the different discharges that you can have. Sometimes you have discharges more on the most of the cases occipital region, but you can have more frontal or parietal region, and sometimes you can also have a very particular photoparoxysmal response at the photic stimulation, and this is probably because the epileptiform abnormalities are more posterior. You can see the length of the seizure is quite long, mainly between 5 and 30 minutes. Some children, they can have more than 1.5 duration of the seizure. The characteristic: impairment of consciousness, vomiting, and eye deviation. If you can characterize this seizure well, you will avoid over-treatment. You can tell the parents an even prolonged episode of autonomic status epilepticus won't be detrimental for the developmental outcome. And the same is true for benign epilepsy with centrotemporal spike. Age at onset is 3 to 14 years, but we know that the main age at onset is between 5 and 10 years. The seizure semiology, you have seen this already, and there is remission of epilepsy and puberty. This is the EEG that I showed you before, and this is a paper that has been published 20 years ago, and we are still talking about this because this showed that 10 untreated and 20 treated patients with Rolandic epilepsy, there was no difference in seizure frequency, seizure recurrence, and duration of active epilepsy. That was similar in both groups. So the question is it really necessary to treat benign childhood epilepsy with Rolandic spikes? We don't really treat it, so I think that this is a case in which the treatment can be withheld. Sometimes you have patients that despite your accuracy, you cannot classify. And in these cases, it's better to use drugs that are effective on a wide spectrum of condition with a low potential for precipitating seizure worsening. And those are valproate, topiramate, and clobazam. Lamotrigine also has a wide seizure range, a wide spectrum of activity, but you have to be very careful if you have myoclonic components, and especially in Dravet syndrome. They can worsen very much the seizure. What do you do, how to proceed when the first monotherapy fails? Then we try to use alternative monotherapy before we move to polytherapy. And the transition from a given monotherapy to an alternate monotherapy should always go through a transition phase in where broad drugs are administered at full dosage. And it is important also to give the time to compare the effect of monotherapy versus combination. Some drugs can work better together, and you have to take the time to evaluate the possibility of synergy. We spoke about epileptic encephalopathy. Our task is to identify the etiology, particularly the etiology that can be treated, because those are severe conditions, but sometimes we can treat them. We can treat them with antiepileptic drugs or also alternative therapies such as ketogenic diet. And we can identify candidates for surgical treatment as well. So what are the metabolic epilepsies that we can treat? Those are treatable, and we don't want to miss them because the prognosis is linked to early diagnosis and treatment. I show you the baby with pyridoxine-dependent epilepsy, and I want to present you this child, who's the first child of healthy and non-consanguineous parents, normal delivery and growth, who started on day 2 with episode of cyanosis, eye deviation, upper limb hypertonia. Neuroexam, she was markedly irritable, fluctuating tone, tremors, and myoclonic jerks. On day 3, an EEG showed a bar suppression pattern, and the diagnosis was hypoxic-ischemic encephalopathy. This is the most common diagnosis in newborn. Every newborn is labeled with hypoxic-ischemic encephalopathy, and we need to be careful and think twice if we are not convinced about this diagnosis. This baby had this diagnosis even if the APGAR was absolutely normal, 8 and 9. She was treated with phenobarbital phenobarbital 20 milligram per kilo. Then the seizure increased in duration and frequency. Then she was treated with levetiracetam, valproate, midazolam, and no response. At this point, she was sedated, she needed mechanical ventilation, and she was hypotonic. An MRI was normal, and she failed pyridoxine 150 milligram IV. And she was transferred at 20 days of life. And this is one of the typical seizures she's having. So she's very irritable, and then she has this asymmetric tonic posturing. You will see myoclonic jerks here and there. She has the saturation, eye deviation. So this is a very complex seizure type. The nurse thinks that she has something in the tube, so she will check several times. And those seizures can be also under-recognized because she will have the saturation, and the seizure type is not the classic clonic jerking you can have for a stroke. Then this was very prolonged. The same is similar to what I was showing you with pyridoxine dependency. You have really alternating seizure here and there. Here is having the tonic phase. But especially in newborn, you really have to be very attentive because the seizure type can be misdiagnosed. And nobody was looking at her. Nobody recognized that she was having seizure. So what we did for this child, this is the EEG, and this is not really a burst suppression, it's more a multifocal EEG with random attenuation, but this is definitely an epileptic encephalopathy. You see no recognizable feature and physiological feature, no differentiation between sleep and awake state. And so what we did a second trial with pyridoxine, because you think about and you see maybe 100 milligram, 150 milligram was not enough, but there was no amelioration. And then we inquired the parents, and we found out that the brother died at 13 days of life, and she was also diagnosed with hypoxic-ischemic encephalopathy, refractory status epilepticus, and sepsis. So we started pyridoxal phosphate 50 milligram per kilo, and this is the EEG afterwards. The EEG is continuous. There is almost no epileptiform abnormalities. This is after 5 days of pyridoxal phosphate treatment. Pyridoxal phosphate dependency is a recently recognized metabolic neonatal epileptic encephalopathy that necessitates rapid and appropriate treatments. There is a mutation in PNPO gene that has been identified, but you can make the diagnosis by trying medication, by avoiding to label children with hypoxic-ischemic encephalopathy if they don't have it. And this is another type of treatable epileptic encephalopathy in newborn period, and this is folinic acid responsive seizure. They have recently been presented, and there are 7 cases with limited response to pyridoxine, but they responded very well to folinic acid. Those are vitamins, pyridoxine, pyridoxal phosphates, and folinic acid. Those are vitamins that can be easily found, and really you can save the child. So what should you do if you have neonatal epileptic encephalopathy that you suspect they can have vitamin deficiency base? You want to take the CSF for neurotransmitter metabolize and amino acid, and you can do it even if you don't have the resources immediately, but you can keep it and put it away and frozen the CSF. And then you can take the blood for amino acid, pipecolic acid, you can take the urine for vanillactic acid, and you can bank the DNA. Maybe in the future you would be able to do confirmatory genetic testing for both the gene of pyridoxine dependency and the pyridoxal 5-phosphate dependency. And then you can try to treat this child. So you start with pyridoxine. If pyridoxine doesn't work, you move on with pyridoxal 5-phosphates, and you can move on again with folinic acid. This is also a rare disorder that is important to identify. This has been recognized by De Vivo as called as GLUT1 deficiency. It's a deficiency of the glucose transporter type 1 gene that is one of the lesser known causes of preventable mental retardation due to this defective enzyme cannot bring the glucose into the brain, and so you have this reduced supply of glucose that leads to seizures, movement disorders, and mental retardation. The phenotype is expanding. It seems that you can have children that they don't have seizure, but they only have marked ataxia or dystonia, or paroxysmal exertion-induced dyskinesia. You have to be very careful, and particularly early onset absence seizure, you have to be very careful to characterize the phenotype. And then you can do a CSF and to check for reduced glucose level compared with the normal blood glucose level. It's important to diagnose it because it's an early onset encephalopathy. Babies are normal at birth, normal Apgar, and then they start to present with seizures, psychomotor delay, deceleration of head growth, and usually also movement disorders such as opsoclonus, ataxia, or dystonia, and all these symptoms worsen prior to meal. It's important to make the diagnosis because you can treat them with ketogenic diet, because ketogenic diet can provide an alternative source of fuel for the brain that cannot get enough glucose, and so you can provide ketones as an alternative source of energy for the brain. And it's very important to make the diagnosis because you should avoid barbiturates that can aggravate the GLUT1 transport defect, has been shown to aggravate the glucose transport defect in erythrocyte of individual with GLUT1 deficiency. So we mentioned about the ketogenic diet. Other non-antiepileptic drug treatments are steroids, and we discuss about the importance of steroids for some epileptic syndrome, including West syndrome, including Landau-Kleffner, and continuous spike and wave during sleep. And recently, immunoglobulin are going back and forth in our practice. We used them a lot 20 years ago, then we abandoned them, and now we are using them again, particularly for drug-resistant focal epilepsy and recurrent seizure in patients with subacute encephalopathy due to a suspect immunomediated etiology, particularly fires. And fires, children with refractory status epilepticus also respond. If they respond also to ketogenic diet. And Rasmussen encephalitis, there are several reports of the use of immunoglobulin, intravenous immunoglobulin. How do we use them? 2 grams per kilo is the same thing that we use for other situation immunotherapy in children. 2 grams per kilo divided in 5 days. If they are not well tolerated, the side effects are fever, irritability, and sometimes tonic-clonic seizure in epileptic patients without history of tonic-clonic seizure. We start to use them in courses, so we do a course of 5 days or 3 days intravenous immunoglobulin every month, and for some children, especially Rasmussen, has been proven to help, to be effective, but they are very, very expensive. Surgical procedure can be helpful. If you identified focal cortical dysplasia or hemimegalencephaly, the earlier you can operate, so the earlier you can recognize the seizure type, make the right diagnosis, and then go to the right treatment, the better. Hemispherectomy or more, hemispherotomy, we are doing now more hemispherotomy, which is only the disconnection without removing the whole hemisphere, and it has specific indication, particularly hemimegalencephaly and Rasmussen encephalitis. And hypothalamic hamartoma can be treated with drug, but can also be treated with disconnection of the tumor in the brain. I don't have too much to say about this parasurgical procedure. I know that they have been pushed very much by the company that produce nervous vagal stimulation. I think I reviewed all literature, and my personal experience, there is modest efficacy in most cases. The best indications are still debated. Sometimes Lennox-Gastaut syndrome, resistant abscesses, or bilateral structural lesions. Mainly the patient you cannot really operate, and so you use this parasurgical procedure. Deep brain stimulation is still an experimental. I wanted to mention that, as well as gamma knife surgery, particularly started to be used for hypothalamic hamartoma disconnection. And this is what I wanted to tell you about this. Thank you.
For want of time, we would like to postpone the question session to the lunch time, provided if your mouths are free. And now that we'll go on to the next session, because anybody who wants to take some rest to the restroom, probably go in turns for two reasons, because there may not be enough space there, and there may not be enough people in the auditorium. And I think we'll go on to the next session now.
Thank you very much, chairpersons. Now I request Dr. ESK to give a memento to Dr. Maria Roberta Cilio. I request Dr. ESK Now I request Dr. ESK to give a memento to Dr. Jayakumar. Thank you very much, sirs. We are moving on to the second session. To be chaired by lead faculty is Donna Ferrero, and chairperson is Santosh Joseph. Donna Ferrero is a professor of pediatrics and neurology and chair of the Department of Pediatrics and physician-in-chief of the UCSF Benioff Children's Hospital. Dr. Ferrero is director of the Neonatal Brain Disorder Laboratories and co-director of the Newborn Brain Research Institute at UCSF. Our laboratory has been critical in defining the role of oxidative stress during hypoxia-ischemia and the relationship of selectively vulnerable populations of neural cells during maturation-dependent injury. She has been recognized by the university and by her residents as an outstanding teacher, receiving the UCSF Academic Senate Distinguished Teaching Award and the Robert B. Laser Neurology Teaching Award. She is active in mentoring programs for medical students, residents, and junior faculty, and she was recognized for these efforts with the UCSF Chancellor's Award for the Advancement of Women and the Maureen Andrew Mentor Award from the Society for Pediatric Research. She is a recipient of the Holy Smith Award for outstanding service to the School of Medicine. She is past president of the Child Neurological Society. She served as on council for the American Neurological Association and American Pediatric Society, and is past chair of NIH NSD, a study section. She is currently on council for NINDS. She is on the editorial boards for several peer-reviewed journals, which include Nature, Clinical Practice Neurology, Pediatric Research, Associate Editor, Annals of Neurology, Associate Editor for Child Neurology. She is the recipient of the 2000 Sidney Carter Award in Child Neurology for Excellence and Leadership in Child Neurology, and was elected to the Institute of Medicine of the National Academy of Sciences in 2005. She received the Royer Award for Excellence in Academic Neurology in 2007 and the Willis Lecture for Outstanding Contributions to Stroke Research in 2010. She was recently elected to the Association of American Physicians. I invite her, I welcome her. Please take your seat. This is regarding Dr. Santosh Joseph, who is Professor of Radiology and Head of the Department of Radiology and Imaging Sciences at Sri Ramachandra Medical College, Chennai. He obtained his MD in Radiology from Medical College, Trivandrum. He established the Department of Neurointerventional Radiology at SRMC, Chennai. He has published over 50 research articles in international and national journals and has extensive 19-year work experience in the field of interventional neuroradiology and vascular radiology. His primary areas of interest are on advanced neurointerventional procedures and management of aneurysms, AVM, and stroke. I request him to take the chair and conduct the session.
Thank you. At the outset, I thank the organizers for having given me an opportunity to be a part of this symposium and also to conduct the session Bench to Bedside, Imaging in Pediatric Neurology, what is contemporary and what is on the horizon by Dr. Ferrario. It's indeed a great, fascinating subject, thinking about the pediatric brain, especially the neonatal brain. We have been extremely fascinated by the different contributions of UCSF. Especially, we have always been fascinated by reading Dr. Bakowicz articles, along with Tom Nadich articles, and I have been fortunate to be a part of clinical rounds meeting while I was undergoing training in UCSF in the year 1993. So, I think there is nothing much to tell about, too much about Dr. Ferrario. She is a researcher. She is a keen interest in neonatal brain, and I invite her to deliver the lecture on imaging in pediatric neurology.
Thank you very much for that extensive and embarrassing introduction. I wanted to thank Professor ESK and the Srinivasan Institute for this incredible honor. I want to thank everybody that we've met so far, especially yesterday at VHS, for a wonderful session and a tour of the hospital and patient demonstrations, and all the students who presented their fabulous work to me. So what I'd like to do in the next, during the next bit of time, and please feel free to take your own breaks since we haven't had a chance to have one, is go over some of the lessons we've learned from MRI, especially about the newborn brain, and how we can use these techniques to not only diagnose patients, but also help with prognosis, to tell families, and possibly to know who to treat. At the end of the talk, I'll go through a couple of patterns that we see with some of the inborn errors and brain malformations that occur during childhood as well. So this is the biggest challenge we have, trying to image this tiny premature or term brain compared to the adult brain. So in order to do that, we've had to develop technical coils, software to get that information. So initially we had only this tiny little plastic incubator to transport these fragile newborns, but with the help with General Electric, we developed the incubator you see on the left-hand side. This is what the prototype looked like, and you can see here that we could put the infant into the incubator. The coil is now right around the infant's head, so that increases the signal-to-noise ratio, and all the monitoring equipment is on the incubator cart. This is the new model by Lammers, which is quite beautiful and very, very expensive. So what we want to do is try to figure out what's happening during brain development as these infants are developing ex utero. And you can see in the preterm brain, this is just a difference of time of about 12 weeks from here to here. Look at the massive changes in the brain in terms of sulcation and gyration. In addition to that, using diffusion-weighted imaging tractography here, these are the fractional anisotropy maps, which tell us directionality. You can see how all the internal fibers are developing extensively over this period of time. And we can also see from these images that the preterm child has a predilection for injury to the white matter, where the term child has a predilection to injury to the deep gray, and that is in response to an ischemic insult. So let's delve into that a little bit more. So why is age such a critical determinant of what we see? This is because there are developmentally vulnerable cell populations, and you're all familiar with the head ultrasound that shows the periventricular leukomalacia in the white matter. Why do we see that? Because these cells, these oligodendrocyte precursors, are extremely vulnerable during this preterm period. And so there's a maturation arrest, and we don't form mature oligodendrocytes, nor the myelin that wraps around the axons to preserve brain integrity. This preterm white matter injury can be very minimal, but this is only the tip of the iceberg, because even though you see here, we're calling this severe, but we're only seeing a couple of white spots. That's because this injury is just showing you just a little bit of what's happening underneath, because I will show you in subsequent slides that when we have injury like this, the brain does not mature properly. And when we look at the MRI scans in these babies, we can see that white matter injury is associated with outcomes. So the more white matter injury, the more abnormal the child. Ventriculomegaly, also with severe, will affect developmental outcome. And when we look at the second MRI, we can see that this still holds up, that the white matter injury is predicting abnormal outcome, ventriculomegaly, and now intraventricular hemorrhage with even grade 1 and 2 shifting outcome over time. And when we look at the clinical predictors of this abnormal development that we're seeing as reflected in the MRI, much of it doesn't pan out except for postnatal infection. Why is that important? Because this is a modifiable risk factor for brain injury. These babies will have progressive injury after birth. And this is a study done by Hannah Glass at UCSF, where she imaged babies at 34 weeks, did not see much, and then saw in some babies this increase in white matter injury. And when she looked at a variety of clinical factors that might be causative of this injury, she found that when she adjusted for gestational age, that recurrent infection was indeed the risk factor most associated. And although we thought chronic lung disease was going to be one of the determinants, when she adjusted in a multivariate analysis, that recurrent infection was even independent of chronic lung disease. So a modifiable risk factor to prevent progression of brain injury. What about the term baby exposed to hypoxic-ischemia? Well, that's a very different picture. And if it's prolonged intermittent hypoxia, we might see watershed injury here in the zones in the anterior and posterior cerebrum. But if the injury is severe, like placental abruption, we're going to see massive changes in the deep gray nuclei. Babies who are born at term can also have white matter injury, but these tend to be babies who are born, we call term 36 weeks to plus 40, but the babies who have white matter injury are really the young term babies, the 36-weekers. So it's not to say that these are exclusive events, that term is only gray and preterm is only white, but there is definitely a continuum as seen in this very nice paper from Steve Miller's group when he was at Vancouver. So how else can imaging inform us about what's happening in terms of how signals occur in the brain and how energy is generated? And probably the most illustrative information we can get is from MR spectroscopy. So we know that there's oxidative stress in the setting of hypoxia-ischemia, and this is particularly important in the newborn brain because these enzymes are just developing, they're not mature, and specifically glutathione peroxidase is very low in the baby brain. So when there's energy failure, there's leakage of superoxide, production of hydrogen peroxide, non-enzymatic conversion to an even worse free radical in the presence of all this free iron that's in the newborn brain. And so this sets up the brain to be uniquely vulnerable in the setting of energy failure. So can we see this? Brain. Absolutely. And here's a baby who was born large for gestational age, shoulder dystocia, required resuscitation. And we can see on the diffusion weighted image that there's changes already in the deep gray nuclei here in thalamus and some of the radiations. But look what's happening. We're starting to see, even as early as 30 hours, an accumulation of lactate as a sign of oxidative stress. If we look 7 days later, we can see progression of that injury over time, and now it's extending into all the white matter tracts that are emanating from those deep gray nuclei. And look, we still have an elevation of lactate. So this oxidative stress is occurring over a long period of time, which tells us we have a huge window of opportunity to intervene for these babies. Also, you can see here the NAA, which is a marker of neuronal integrity, is normal at 34 hours, but a week later, it's half the size of a peak, telling us that we've had experienced neuronal dropout. And we can associate these changes that we measure on day 4 or 5 of life with outcome in a 2.5-year-old child, and we've done that. And these patterns are consistent with abnormal outcome, the ones I just showed you, the low NAA and the lactate, both in the deep gray nuclei and in the intervascular boundary zones. So that's what's happening acutely at the time of birth. What about as the brain matures? Can we watch any of this using MRI? And can we tell whether these injuries that occur at birth are affecting the maturation and repair of the brain? So we can turn to diffusion-weighted imaging now, and diffusivity tells you about the organization of the cortex, and I'm going to show you that in the next slide. And FA is fractional anisotropy, and that tells you about directionality. So that's all your track formation. So we can measure babies at 28 weeks gestation and then at near term and see what's happening with these factors. And Savannah Partridge at when she was at UCSF showed very nicely that in normal babies, white matter development shows this increasing FA or anisotropy as all those white matter tracts form, and diffusivity decreases over time as the brain becomes more organized. Gray matter, as it becomes more complex, loses that radial formation that we see in the very preterm baby. And we see increasing complexity in terms of gyration and sulcation, as I showed you on that very initial slide. But what happens if there's injury to the brain? Well, we see something happening to these parameters. So the average diffusivity, as I just told you, should decrease with age in all regions. But actually it's increased where we see those little white matter ditzels that I showed you on the previous scans. And likewise, fractional anisotropy, as I told you, in the white matter should show a very nice symmetric increase over time. But what happens when there's injury, like those little white matter spots? There's absolutely no increase in fractional anisotropy. So the brain is being affected in terms of its maturation. So it's not just a solitary event, it's an event that is now impacting on the development of the newborn brain. We can also use advanced imaging techniques to look at function in the newborn brain, and we use diffusion tractography. Here you see the beautiful fiber tracts in the corticospinal tracts coming through the internal, starting in the cortex, going through the internal capsule and into the cerebral peduncles. And we can look at these beautiful tracts by diffusion tractography and correlate them very nicely with outcome. So neuromotor score 0 is a normal child, 5 is a child with spastic quadriplegia. And when we look at those measures of fractional anisotropy, they correlate beautifully with neuromotor outcome. Likewise, we can look at visual function in the newborn and compare it to what we're seeing on their MRI score. And here again, using diffusion tractography, we can see the beautiful optic radiations. And when we measure fixation score in these neonates over time, we should see a nice increase with age. And this is definitely disrupted in babies who have abnormal scans. What about the babies who have systemic disease? Is systemic disease impacting on the developing nervous system? The answer to that question is absolutely. So here's a baby with congenital heart disease born at term. But I told you that term injury should just be manifested in the gray matter. But we're seeing term injury in the white matter in these babies. And when we look at a scan from a premature newborn, like I just showed you, we're seeing exactly the same pattern. What does that mean to us? That means that the brain of a baby with congenital heart disease is not developing normally. And we can use measures on MRI to prove that. And this was published by Steve Miller in the New England Journal of Medicine a number of years ago, where we measured against a control group the spectroscopic changes and the diffusion changes and found that the babies with congenital heart disease just were not developing and maturing over time. What about babies who have stroke? As you know, and I'm going to tell you again tomorrow, neonates have an incidence of stroke that is as high as those in the elderly population. It's enormously frequent. And we can look at the scans of these newborns if we can detect the injury at birth and determine what their motor outcomes going to be. A little bit of a crystal ball. How do we do that? Again, we go back to our diffusion parameters, and here we can see that the affected tract is thinner than the non-affected tract in this baby who had a middle cerebral artery stroke and then imaged at 3 years of age. So what can we use to predict these changes? This is a baby born at term. Here is the infarct, middle cerebral artery. I think you can see it both on the flare and also on the T1 images. And what we're seeing here is signal abnormalities in the corticospinal tract. And we can measure this, and Adam Curtin did this very beautifully, quantified these measurements of that corticospinal tract and could relate that to the degree of hemiplegia seen later in life. So seeing this signal will tell us that this child is set up for a motor abnormality, and we must intervene appropriately with good physiotherapy in this child. So what about learning from MRI in terms of all the genetic conditions that affect the brain? Looking at patterns of injury, we can learn much and diagnose almost completely with, as you mentioned, the wonderful work of Jim Barkovich. And these slides that I'm going to show you now are from his library. He was very generous to give them to me. We can also learn about cortical development through the appearance of brain malformations, and I'm going to show you some of those pictures as well. So here is a condition of white matter abnormality, a leukodystrophy, metachromatic leukodystrophy that many of you are familiar with. As you know, it's caused by decreased activity of aryl sulfatase A, which results in myelin breakdown and lack of myelin reutilization in both the central and peripheral nervous systems. It can present at any time, but usually presents late infantile with a gait disorder, often strabismus, spasticity, increasing intellectual deterioration, and speech abnormalities. What do we see on the MRI? We see diffuse white matter injury that is very, very symmetric. This is very different from the white matter injury I showed you associated with preterm injury from hypoxia-ischemia, isn't it? This is diffuse, dense white matter injury and very symmetric as opposed to asymmetric. Another leukodystrophy, Krabbe's disease, or globoid cell leukodystrophy, is caused by galactosylceramide beta-galactosidase deficiency, which results in destroying the oligodendrocytes themselves, so myelin never even forms, as opposed to metachromatic leukodystrophy. This also can present at any age, but it really presents in the first few months of life. Infants come in with a very big head, they're extremely irritable, they have very increased reflexes to begin with, and marked delayed development. And we see a very particular pattern on their both CT and their MRI. And we noticed this years ago on when all we had was CT. We were seeing these hyperdense formations in the thalami bilaterally. The thing you should always keep in mind about inborn errors and of metabolism is that their imaging characteristics should always be symmetric. It's a tip-off. If you see this symmetry, you must think of an inborn error of metabolism. And here you can see this absolute symmetry in the cerebellar dentate nuclei and in the deep white matter in this infant with Krabbe's or globoid cell. Here's another white matter disease, but instead of destruction of myelin, there's no formation of myelin in this disorder called Pelizaeus-Merzbacher disease. This is a child who came to us with this diagnosis of cerebral palsy, but he had abnormal lightning-like eye movements, extreme spasticity, and when we scanned him, we saw these changes in his brain, the symmetric changes in his deep gray nuclei involving globus pallidus and thalamus, as well as a total paucity of myelin on the MR scan, and we see that reflected in markedly depressed creatinine and choline peaks on the MR spectroscopy. What about mitochondrial disorders? They can also present with very classical imaging findings. And what we see are abnormal T2 prolongation, primarily in the corpus striatum. And I'm going to show you that in a minute. You can see involvement of the brainstem in some of the subtypes of this syndrome and involvement of the deep white matter and corpus callosum in the respiratory chain deficiency types of Lee syndrome. Myelination delay is common, and the MRS will tell us that this is a mitochondrial disorder because we'll see persistent elevated lactate and reduced NAA, that marker of neuronal integrity. And we will, if we measure CSF lactate, we'll see an absolute elevation. And this is what the scan looks like. You can see here the cerebellar abnormalities. Again, look at the marked symmetry here that we're seeing on this scan. And then look at the putamen. Again, marked symmetry in the nuclei, as well in the whole corpus striatum, but particularly putamen and globus pallidus. And then when we look at the spectroscopy, the lactate peak is enormous. It's almost as high as the NAA peak, telling us that there is energy failure and a suspicion of mitochondrial disease that we can then go on to hone in our diagnosis with appropriate evaluation. Maple syrup urine disease doesn't usually present in the newborn period, more so in childhood, but it also has these characteristic symmetric findings that involve white matter. And what you'll see with maple syrup urine disease, even if you control it well with diet, is that this intramyelin edema and white matter signal continues to progress despite therapy. Here's a peroxisomal disorder, Zellweger's, which has an absence of normal peroxisomes. We see the neonate with very abnormal facies, the wide metopic sutures and the broad forehead, seizures in the neonatal period. These babies have absent myelin as well, like the leukodystrophies. But in this situation, the disease is confounded by the appearance of cortical malformations. Here you can see polymicrogyria, and also the germinal-lytic cysts, which I think you can see carved out here next to the lateral ventricles, is really a hallmark of this disorder. So if you see germinal-lytic cysts, cortical malformations, and lack of myelin, you must think of Zellweger's and send the appropriate peroxisomal workup. X-linked adrenoleukodystrophy, another disorder affecting white matter, another peroxisomal disorder where long-chain fatty acid transport is dysregulated, resulting in accumulation of long-chain fatty acids in the serum, and you can measure them to make the diagnosis. We see this in boys, usually at the end of the first decade of life. They present first with a learning disability, or they've always had a bit of a learning disability, and then comes the gait disturbance. The MRI is particularly helpful because the corticospinal tracts will be involved from beginning to end. So please look for that when you are considering this diagnosis. And here you can see the involvement right down into the brainstem of the corticospinal tracts. This is sometimes seen even before they manifest any motor difficulties. So if you see this, please send long-chain fatty acids in these young boys. I heard last night at dinner that Wilson disease is quite common here in India, and this is a disorder also called hepatolenticular degeneration. We don't see it in the newborns, but we see it in children manifesting as liver disease as opposed to brain disease, but in young adults with neurologic deterioration. And when detected early, we can really impact on disease prognosis. So it's important to use the MRI imaging findings to help with your workup of disorders of copper metabolism. And here we can see in this 10-year-old who actually presented with encephalopathy on the T1 weighted images, shortening in the globus pallidus, especially the putamen. And here you see it again, this marked symmetric involvement here in the putamen. Again, symmetry, symmetry, symmetry. So what about brain malformations? Some of these are very easy to pick up on head ultrasound in the newborn period for sure, and even this condition you could probably pick up with transilluminating the infant's head, but you won't know whether it's a bad schizencephaly, an anencephaly, or holoprosencephaly. In this case, this is an example of alobar holoprosencephaly, and you can see that all that's left is some remnants in the frontal regions, markedly devastating diagnosis. Semilobar holoprosencephaly is a little harder to distinguish on head ultrasound, although you may see the abnormalities in the ventricular system, but what you're seeing are fused thalamic nuclei and the lack of callosal efferents and afferents. Mild lobar holoprosencephaly really is hard to detect on ultrasound, and MRI reveals the fusion, the small fusion anteriorly, lack of fusion below that. There's an holoprosencephaly that has a large interhemispheric cyst. This is a variant, and it's called syntelencephaly, and this can be picked up on head ultrasound, but you would need the MRI to define how much of holoprosencephaly you're dealing with in this situation. Another devastating disorder. Polymicrogyria can be seen after insults or because of abnormalities of neuronal migration, and we can see it in the perisylvian regions right here. And if we see this, we should scan mom as well. Parietal regions, paroccipital regions, frontoparietal regions. So a variety of syndromes of neuronal migration, which usually present with very refractory seizures that you've heard about in the elegant discussions by Dr. Cilio. There are a whole host of genetic disorders that affect brain development, and here's just one example of lissencephaly, the LIS1 mutation, and this is kind of like, this is smooth cortex. There are absolutely no gyrations or sulcations, something that we can pick up on head ultrasound, but much easier to define. And when you see this, it's important to do the genetic testing for the family if you can. There are a whole host of disorders associated with agenesis of the corpus callosum. So in this situation, this is the beginning of the workup, not the end of the workup. So all you can say is, there is no corpus callosum. Let's find out what we're dealing with. Look at the eyes. Does the child have seizures? Is it a girl? Is it Aicardi syndrome? On and on. The list is very long. Dandy-Walker malformation often can be tipped off by that huge occipital prominence that we see in these children. And here's this huge cyst, fourth ventricular cyst, that you can see nicely defined on this angiographic image. Big foramen magnum with fourth ventricular changes in dilatation with cortical atrophy. Molar tooth malformation, this one also has a hypothalamic hamartoma that Dr. Cilio talked about. This is also called Joubert's syndrome, but Joubert's is now much broader. Might present in the newborn period with that funny breathing. It's kind of panting like a dog. and you worry about that, so you get the scan and you see what has been called very smartly, I think, the molar tooth. So those are a number of the malformations that we might see in children that can be detected on MRI. So I want to end up by hoping that I've convinced you that these techniques can first tell us and provide for us a window on the timing of injury. We can use, like I showed you in the spectroscopic image, we can see that the lactate is accumulating over a week's time. In a neonate with stroke, we can watch that infarct bloom over a week, and that tells us we have time to intervene, much longer than we do in the adult, where we feel, for example, with an adult with a stroke, we have to get the TPA in within 6 hours. These techniques can provide information about neurodevelopmental outcomes, so they help us talk with the family about a prognosis for these children, and we could see that using the diffusion imaging and looking at the corticospinal tract and the cerebral peduncle. If we see that signal abnormality on the diffusion image, we are pretty sure there's going to be congenital hemiplegia that we have to deal with. These techniques can yield important information about brain development, even in the absence of structural brain injury. And I showed you that. You look at those scans of the babies with those little white matter ditzels and you think, so what? It's just a little tiny ditzel. But in those babies with those little tiny ditzels, what we're seeing is a profound and widespread disturbance in brain maturation. And we can measure that using our spectroscopic techniques, and we can do that using our diffusion techniques. These techniques also correlate very nicely with neurodevelopmental outcome. So if we see these abnormal patterns at or near the time of birth, we can tell from those patterns who is going to be challenged. And these pieces of information put together can help us inform the family for the care of that child. And through pattern recognition, MRI provides an enormous amount of information about diagnoses of inborn errors of metabolism and brain malformations. And I hope I've left you with the teaching that I received from Jim Barkovich, that a symmetrical lesion is an inborn error of metabolism until proven otherwise. So I thank you for your attention. Many people have contributed to all of this wonderful information, and I'm really blessed to have incredible colleagues at UCSF. Thank you for
that is affecting the they contributed to the understanding. It's also has been extremely important to have a clinical correlation between the imaging and the development of neurological outcome. So that sometimes you find that the MR looks like extremely florid, but the child will not be that much symptomatic at all. Right. And on the other hand, you see a small speck on the diffusion weighted image. At the same time, the child will be extremely bad in behavior. I think we have some time if we have any clarifications or queries, and probably we can ask questions to Dr. Ferrerio.
Ferrero, wonderful, wonderful presentation.
Thank you.
I'm Radha from Brooklyn, New York. And my question was, in the neonatal strokes, when we see the huge MCA, and eloquently the DTI shows the tract, but time and again with the early intervention, I find that if it's only stroke and it's not HIE, that many of these babies do very well. And so as the follow-up, how have those tracts changed in the ones that have done very well and don't show hemi or seizures or any intellectual deficit? And if I didn't tell them their original MRI, nobody would believe that they had had a stroke.
That's a wonderful question, and I had a slide on here which I hid. Let's see if I can get that back up for you. Unhide that, if I may. Oops. Can we get that back up? Okay, so maybe the light's down just a tad. So thank you for that question. We know from animal models, if we see absence or diminution of tracts, we're going to see abnormal development, and we can plot that over time. And this is an animal injured at 7 days of life, a rat, and by a P42, when it's a mature adult, there's absence of the fimbria fornix and subsequent tracts that correlate with deficits seen in those animals. What about the human? What about the human with a stroke? What's the information that's telling us this is good or bad? One of the pieces I told you about was this signal that we see in the corticospinal tract at or near the time of birth. So here's a baby with an MCA infarct imaged at birth, and then again at 3 months of life. So in a patient with severe hemiplegia, that 3-month scan is going to show an abnormal tract. The patient with mild hemiplegia will not show any abnormalities in that tract. So we can use the imaging to distinguish mild from severe, but the real question is, why is this baby with a huge MCA infarct not affected while this one is? And that's the $1 million question, I think.